Welcome to Editor's Choice, the podcast at EuroIntervention, where we highlight the latest science and research in interventional cardiology. I'm your host, Aaysha Cader, and through conversations with the authors, we explore study design, key findings, and their relevance in contemporary practice. I'm delighted to be joined today by Dr Birgitte Andersen from Aarhus University Hospital in Denmark, and we will be discussing the paper titled Quantitative Flow Ratio versus Fractional Flow Reserve, 2-year follow-up of the FAVOR-3 Europe trial. Welcome to the podcast, Dr. Andersen.
Thank you very much, and I'm delighted to be here. So thank you for the introduction.
Perfect. So your paper, published in this issue of EuroIntervention, reports the 2-year follow-up results of FAVOR-3 Europe. This was, of course, a non-inferiority trial and the first adequately powered RCT comparing QFR and FFR, the primary results of which were published in 2024. Tell us a bit about the background to FAVOR-3 and very briefly recap for us its main results, please.
Yes, of course. So first, a bit of background. And as all of you know, physiological assessment of intermediate coronary stenosis is recommended when guiding treatment decisions. So the problem is that the society recommended pressure-wire derived indices, FFR and IFR, remains underutilized. To overcome some of these challenges with the pressure-wire-based methods, QFR and also other methods that offer angiography-derived FFR was developed. And this study focuses on QFR. QFR is a computer-based method that allows for estimation of FFR without pressure wires and without adenosine. It is based on 2 angiographic images, and it can be calculated within the procedure and within just a few minutes. So it's feasible and fast. And the FAVOR-3 Europe trial was, as you said, the first adequately powered RCT to compare angiography-derived FFR with pressure wire-based FFR. It followed a large body of primarily positive evidence, which included prospective studies that showed very good agreement between QFR and FFR, and therefore we felt ready to engage with this large RCT. FAVOR-3 Europe was an investigator-initiated, open-label, multi-center trial, and we enrolled 2,000 patients across 34 European centers. And the primary endpoint was 1-year MACE, which was a composite of death, any MI, and any unplanned revascularization. And the study was powered for non-inferiority at 1 year. And as presented in 2024, the patient population represented a standard European population with intermediate coronary artery disease. So 1/4 were female. Most patients, around 2/3, presented with chronic coronary syndrome. The mean age was 66. 1/4 had diabetes, and half of the patients had previous PCI. And also importantly, these baseline characteristics were similar between the groups, which indicated a successful randomization, which is important, of course. And the expectations for the main results back in 2024 were very high. But QFR did not meet non-inferiority to QFR at 1 year. So a MACE event had occurred in 6.7% in the QFR group, while only 4.2% in the FFR group. And the difference was mainly driven by more MIs and unplanned revascularizations following QFR guidance. There were no meaningful difference in mortality. Furthermore, I would like to add a notable finding, and that was the revascularization rate in the intermediate lesions that were measured. And this was significantly higher in the QFR group, with a 21% increase in revascularization following QFR, and that resulted in 27% more stents implanted in study lesions in the QFR group compared to FFR. I think that is a short recap of the main findings.
Yes, that's a great summary of the primary results of FAVOR-3 Europe. But in this study, you looked at longer-term follow-up at 2 years. Could you tell us the results of this 2-year follow-up?
Yes. So at 2 years, a MACE event had occurred in 9.7% in the QFR group and 7.4% in the FFR group. The hazard ratio was still in favor of FFR, 1.34, but the 95% confidence interval exactly just crossed unity, and the p-value was 0.06. And I have to say here that, of course, this 2-year analysis was not powered, and therefore we also did not look for a significant result, but look for the direction.
Okay, and you also conducted additionally a post hoc landmark analysis of 1 to 2 years. What were these results, Dr. Andersen?
This post-hoc landmark analysis showed that the MACE rates from 1 to 2 years were exactly the same, so 3.2% in both groups with a hazard ratio of 1. So we found no further divergence of the incidence curves from 1 to 2 years, but also we did not find any convergence.
Okay, and additionally, per protocol analyses as well as a win ratio were conducted. Could you explain why these were done and what their findings were?
Yeah. First of all, the per protocol analysis was performed both at 12 months and now again at 2 years. And it was a predefined sensitivity analysis, which is, for me to see, appropriate in all non-inferiority trials, because having a lot of crossovers would cause a risk of concluding non-inferiority. So it's important in all non-inferiority trials, at least as sensitivity analysis. But this analysis included patients with successful QFR measurements in the QFR per protocol group and vice versa. And the results of the per protocol analysis supported the main findings in favor of FFR here at 2 years with a hazard ratio of 1.40, and the confidence interval was from 1.02 to 1.92. So it supported the MACE result. And then further to the win ratio. And this was not a planned analysis from the beginning, but it has really catched on the latest years. And we therefore decided to conduct a post-hoc win ratio analysis when we reported the main results. And we repeated this at 2 years to be consistent. And the results were again similar to the main findings, also in favor of FFR, so the win ratio was 1.76, which means this can be difficult to understand, but I like to say it as the odds of a QFR patient having a better outcome than an FFR patient in a random pair of patients.
Okay, and all of these analyses put together, what should readers take away as, in addition to the primary results of FAVOR 3? What is the ultimate conclusion from the 2-year analysis?
Yeah, and as this is the final planned follow-up, this is, of course, the most interesting question. And as the present 2-year analysis was not powered, the 1-year primary endpoint and its conclusion that QFR did not meet non-inferiority to FFR remains central. So importantly, as I mentioned before, there's no evidence of convergence of the MACE curves after the first year that could suggest a delayed benefit of QFR. So the numerical difference between the group was sustained, and we believe that the difference at 1 year remains clinically relevant. So I think the message remains the same. The investigated method of QFR is not as good as FFR.
And we will revisit that later on in this podcast. But before that, I did want to ask you, how would you explain the similar event rates for QFR and FFR arms after the first year?
So the difference between the groups are truly the intervention. So the diagnostic modality guiding whether or not an intermediate lesion was revascularized or deferred. And our results indicate that the potential adverse effects of a wrong decision in this regard is mainly realized within the first year. Our results also show that the event rates both at 1 and 2 years are very low in this population. And the number of events related to the actual intervention is low from 1 to 2 years, and other events that are not related to lesions measured by QFR or FFR, and therefore also expected to be equally occurring in the two groups, dilutes the event rate difference. So you could say that the risk difference related to the difference in the diagnostic modality may be diluted by all the other things that these patients are at equal risk for.
Additionally, while the QFR arm resulted in excess revascularization, you also found that increased event rates for QFR at 1 year were reported for both the treated as well as the deferred patients in this arm. How would you explain this in relation to the QFR technology?
I think we answered this quite well with the repeat QFR study that was published in EuroIntervention in January. And here we show that the reproducibility of QFR is modest. Similar concerns were raised following the QREP study that was published back in 2022. And a QFR calculation, the QFR technology, relies on several steps and each potentially introducing some user variability. And I know that with the newer versions, we investigated version 2.0, and with the newer versions, more automations have been introduced. But this version 2.0 does not seem robust enough in terms of reproducibility. And this may have led both to false negative and false positive QFR results. And both of these, according to our results, seem to be driving the event rate difference at 1 year.
This is such an interesting space and so rapidly evolving, because we know, following on from the first FAVOR-3 China trial, which showed better outcomes for a QFR-guided strategy compared to angiography-guided strategy, QFR then received a Class 1 guideline recommendation. Now we have more recent data to suggest non-inferiority of 3D quantitative angio-based vessel FFR and FFR angio compared to an FFR-based strategy. So with all of these other angio-based physiology applications being developed, what would you say should future research focus on?
Yeah, first of all, it is, of course, very promising for the field of angio-based physiology that FAST-3 and ALL-RISE met the non-inferiority target. So that is very, very positive. However, both studies reported significantly higher revascularization rates in the angio-derived FFR groups than with pressure wire-based assessment. And that is just as the FAVOR-3 Europe trial. And therefore, we know that angio-derived FFR may have many potential advantages, both in terms of flow and accessibility. But there are also a lot of things that we still do not know. So how much training is needed? It may be different from the different applications. Is it cost effective? We also do not have very good evidence about this. And especially bearing in mind the higher revascularization rate, I think cost effectiveness is quite important to investigate because we keep telling ourselves and everyone that it's cheaper, but do we have the evidence to back it up? I'm not sure. The hope is, of course, that these new methods could increase the utilization of physiological assessment of intermediate stenosis worldwide. That is the aim and the hope when starting engaging in this technology. But I do not think that it's time to throw the pressure wire away just yet. Other important things in terms of future research is, of course, as I mentioned, the concerns regarding reproducibility. Does this only apply to QFR, and how much does it apply to the newer versions of QFR? And how is it with the other methods, the VFFR and FFR angio that was just confirmed non-inferior? So I think that is important to dive or look a bit more into. We know that angiographic quality is crucial for reproducibility and likely for a reliable QFR or other angio-based FFR result. And it seemed in our trial that inadequate image quality was not always identified, or at least not always possible to fix, and build in warnings in the software, maybe a solution to avoid this. But some research focusing on when is angio-based physiology appropriate and when can we rely on angio-based physiology, because maybe it's most appropriate in more simple coronary lesions with good visualization, and maybe we can do it in 50%. But we still need to have some personnel that are trained in doing it, and they need to be working that day. And so the cost effectiveness, the reproducibility, the image quality, the different populations and lesion-specific pitfalls, I would say, is important.
Perfect. Certainly a very interesting and exciting space. Dr. Andersen, thank you very much for discussing the long-term follow-up of your trial, as well as contextualizing the more recent data that we have in this space. And thank you very much for your insights.
Thank you so much for having me. It was a pleasure.
Thank you for listening to Editor's Choice. To read the full article discussed in this episode, visit EuroIntervention.org. And if you've enjoyed this podcast, please subscribe to Editor's Choice for more conversations behind the science published in EuroIntervention.